Hi everyone, I'm Dr. Sana Ansari. Welcome back to my channel. Today we are learning about gonorrhea and chlamydial infection based on BASHH guidelines. Very important if you're preparing for MRCOG part 2. So let's get started. Now first coming to gonorrhea. It is caused by Neisseria gonorrhea, a very important MCQ. It is a gram-negative diplococcus transmitted through sexual and vertical route. Another MCQ, the incubation period is 1 to 14 days. Coming to the clinical features, another hot question. It is asymptomatic in 50% of individuals. Most common presentation is mucopurulent cervicitis. Another common question. Other presentations are intermenstrual bleeding or postcoital bleeding. Rectal and pharyngeal infections are often asymptomatic and it causes disseminated infection in the form of arthritis and dermatitis. How do we diagnose it? Another important question. By nucleic acid amplification testing, that's a test of choice. Now, culture is mandatory if you're checking for resistance. Vulvovaginal swab is the specimen of choice in women. Another important question. The test is always done after 2 weeks of exposure with infection. Coming to the treatment, ceftriaxone 1 gram IM single dose is given. If you're suspecting chlamydia, also add doxycycline. In case of pregnancy, again, same treatment. Test of cure is required if there is pharyngeal infection. Another important question. Now, if there is a complicated infection, the antibiotic instead of a single dose is given for 7 days. Change to oral form after 48 to 72 hours. So initially we give IV or IM, then we change to oral form after 48 to 72 hours if the patient is improving. So the clinical scenario usually comes as pain in the lower abdomen, fever, mucopurulent discharge, and they'll ask for the treatment. Now coming to the chlamydia, it is caused by Chlamydia trachomatis. It is an obligate intracellular bacterium. Now this is a very important question. It is most common bacterial STI worldwide. Another hot MCQ. The incubation period is 7 to 21 days. Coming to the clinical features, mostly asymptomatic but can cause mucopurulent cervicitis, postcoital and intermenstrual bleeding. Now, why I am telling you these cervicitis, postcoital bleeding or intermenstrual bleeding? Because the questions usually come in the form of the presentation. Patient has come with cervicitis, patient has come with postcoital bleeding, and you have to identify the organism. Complications include PID and in long term can cause infertility or ectopic pregnancies. Conjunctivitis in newborn, this is very important. The treatment of choice is erythromycin. How do we diagnose? Again, similar to gonorrhea, nucleic acid amplification testing is the investigation of choice. Vulvovaginal swab is preferred. This is also similar to gonorrhea and test is done after 2 weeks of exposure. Treatment, the drug of choice is doxycycline 100 milligram twice daily for 7 days. In pregnancy, we can't give doxycycline, that's not safe. So if the question comes the drug of choice in pregnancy for chlamydia, that will be azithromycin or erythromycin. Test of cure is only done in pregnancy after 4 to 6 weeks. These are all very important questions. Now coming to the partner management, because these questions are also asked frequently. Now for the gonorrhea, we treat all partners she has been exposed in the last 2 weeks. Chlamydia, partners in the last 6 months. Advice for abstinence until both have completed the treatment and always consider co-infection with chlamydia or gonorrhea. Let's practice some MCQs. A 24-year woman with mucopurulent discharge. Nucleic acid amplification test is positive for gonorrhea. The next best step is azithro, ceftriaxone, cipro, or no treatment. Which options will you choose? So for gonorrhea, the treatment of choice is B, ceftriaxone, 1 gram IM single dose. Another MCQ, pregnant women diagnosed with chlamydia. The best treatment. A is doxy, B ceftriaxone, C azithro, or no treatment. So this patient is pregnant, so the treatment of choice is azithro. If she was not pregnant, then the treatment of choice will be doxycycline. Another MCQ, which requires routine test of cure. Uncomplicated genital gonorrhea, pharyngeal gonorrhea, non-pregnant chlamydia, or treated male urethritis? Which one would you choose? The correct answer is pharyngeal gonorrhea. So this was all about chlamydia and gonorrhea. Everything related to chlamydia and gonorrhea based on BASHH guidelines I've covered for MRCOG Part 2. Let me know in the comments which topic you want me to cover in my next video. All the best. Thank you.